I want you to think about a time when you or a loved one was in hospital. I want you to think about a time when you might have had your wisdom teeth taken out in surgery. I want you to think about a time when maybe you had a cold or a flu or some stomach cramps, and the doctor gave you some tablets to help you with the pain. The fact is, if we look, opiate-based drugs are all around us. We find morphine as a critical drug in our health system, which relieves pain and suffering for people in hospice care and after surgery. We find hydrocodone and OxyContin and other powerful opiates that also help people with their pain. And we also find other opiates in a few other places. I actually have some right here in my pocket. This is paracetamol and codeine. This was prescribed to me by a doctor to help me when I was suffering from some stomach cramps around the new year. And there's something that's really important that's written here on this box. It says, can cause addiction for 3 days use only. Now, the last time I'd been prescribed opiates prior to this was when I had my wisdom teeth taken out. And my doctor gave me a bottle with a 16-day supply of hydrocodone. 16 days. Remember that box said 3 days only. Now, I only needed the first day, and then I was fine. But this issue of overprescription happens all around the world. And it's happened probably to several people in this room, I'm sure. So what happens to those extra drugs? Do you take them? Do you save them for later? Do you flush them down the toilet? A lot of people actually take the full course. And sometimes, if it's hurting a little bit extra, they might take 2 or 3. This can start a move down a slippery slope. Soon they might be asking their friends if they've got any left. They might go to the doctor, ask for more. And some people, where cost becomes a constraint, might go to the street, looking for more painkillers off the street, and eventually may find themselves looking at heroin or fentanyl or other very dangerous opiates that are incredibly addictive and destructive. Now, these opiates that you find on the street, people start out by smoking them or snorting them, but most people eventually end up injecting them, because the fact is that they go to the street because cost is a problem. And the most cost-effective way to consume most drugs is by injection. You can get the most highs per pound. This is where the opiate crisis intersects with another major public health crisis, that of HIV. Most of us think of HIV as a sexually transmitted illness, which it is. And it's not an illness, it's actually just a virus, the illness that is associated with AIDS. And that's a really important distinction to keep in your mind. Now, HIV is also bloodborne. It's transmitted through contact with infected blood. Now, that's important because if you're sharing a needle with somebody, you're contacting that blood. See, when you have sex with somebody, there's usually around a 1 to 10% chance that you'll transmit that infection, depending on a variety of factors. If you're sharing a needle with somebody, that rate goes to above 90% chance of transmission. So, if you have a single cell of prisoners, and one person has HIV and is not on treatment, and they share that needle with all of the other prisoners in the cell, 9 of those 10 prisoners could seroconvert and become HIV positive. So it's pretty clear, if you have a cluster of injecting drug users, there's enormous risk for additional epidemics of hepatitis C, HIV, and other bloodborne illnesses. And that's a really serious challenge that we're not necessarily equipped to handle. The millennial generation is going to be bearing the brunt of this, not only because it's going to be our loved ones, our parents, our brothers and sisters and friends, they're the ones who are going to suffer from this, but because the rehab facilities just aren't there. This addiction is so powerful that the average person requires 6 attempts to stop using, and the withdrawal symptoms are excruciatingly painful. They're so painful that a lot of people actually are not able to stop, and a lot of people end up dying of an overdose before they get to that 6th attempt. So if we don't have the rehab facilities, what are we going to do? A lot of those people might overdose and end up in A&E, and that's our tax dollars paying for that as this crisis grows. Going beyond that, though, millennials are also more at risk of becoming drug dependent themselves. Our generation is so impacted by increasing levels of stress, depression, anxiety, and the fact that our lives can be so increasingly unstable at home and in the workplace is causing drug use and drug dependence among millennials to increase at alarming rates. We've seen death rates in the United Kingdom increase very, very rapidly, even as the number of people who are using drugs drops slightly overall. From 2015 to 2016, the death rate of overdose in the UK increased by 10% in a single year. 10%. It's enormous. This crisis is only growing. And that's what I'm here to talk to you about today. Because there's solutions to this that are not being tried and are not being looked at. And they come from places that you might not expect. In this case, the solution that I'm bringing to you comes from Iran. Now, Iran's not exactly a place you'd associate with an extremely progressive HIV or drug use policy. But I had a really great opportunity to research this topic in Iran, in Tehran and Isfahan, back in 2012 as a part of my undergraduate dissertation research at Harvard. And while I was there, I had the chance to visit a number of these clinics and talk to a lot of these doctors and researchers and policymakers that are really making a huge impact on opiate-dependent people in Iran. But before I get to that, I want to just start out with a little bit of geographical picturing in our heads. So if you pull up a map of Iran in your head, right? I think we've all seen a map. You see Iran is between Afghanistan and Europe. Europe is where we're consuming most of these drugs, and Afghanistan is where most of them are produced. Most of them have to travel across Iran in order to get to market, which means that there's enormous amounts of opiates and heroin that are available in Iran. In fact, one person that I spoke to while I was there said that in some places, it's cheaper than alcohol. So if it's all there, there's an enormous risk of use, enormous opportunity for this to become a massive crisis. And in fact, Iran has one of the highest rates of drug use in the world. Over 2% of the population used opiates was the statistic that I saw last. So this is a huge challenge facing Iran. Now, HIV first came to Iran in only 1988, and it was very, very small. But it wasn't until the mid-90s that a team of researchers really started to focus attention on it. They were studying health issues facing prisoners in a prison in Iran, and they noticed something. They noticed that suddenly there was a massive cluster of prisoners that were HIV positive, and nobody knew how it had happened. And they went and they started digging on this, and they found that these prisoners were cramped 10 to a cell, and they were sharing needles to inject heroin. Exactly like we saw. Having that shared needle caused a massive outbreak very, very quickly across multiple prisons in Iran. Around the same time, the academic discourse surrounding addiction was shifting. So for a very long time, addiction was viewed as a sort of moral failing, and there's a lot of people that still see it that way today. But as I mentioned, addiction is actually a chemical dependence that forms in the brain, because heroin and other opiates actually change your brain chemistry so that you demand it, and you experience extreme physical pain if you don't take it. This is an illness. And in the late 80s and early 90s, the literature was shifting to really accept that. And that's a big deal, because just about every major world religion tells us that we should help the sick. So in finding this shift, Iran was able to justify an opiate treatment program under the guise of helping the sick. So Iran developed a program of harm reduction. Now, what is harm reduction? Harm reduction is a collection of policies that seeks to reduce the negative impacts associated with unhealthy behavior. It reduces the harm. So a really great example of this that I love to talk about is in my country, the United States, where studies have shown that schools that provide free condoms in the bathrooms for students to take actually have a lower rate of teenage pregnancy and a lower rate of sexually transmitted infection than schools that teach abstinence-only sex education and don't provide condoms to students. Another really great example that I was exposed to here in the UK is if you go to, say, an electronic music festival, you might find that there's free water available in a lot of places, and there's a table where people will take their tablets to get tested to make sure they know what they're taking. These are small things that help people reduce the amount of harm that they do to themselves from unhealthy behaviors. So in the context of opiate use, the way that harm reduction is approached consists of a bunch of different kind of policies that work together to reduce the negative impact. So they include things like STI testing and treatment. They include condom distribution, needle exchange, safe injection spaces where people can be supervised to make sure that they have healthcare in case they OD or they miss a vein. There's maintenance therapy, which I'll talk about a little bit more later. And there's something called naloxone. Naloxone is like an antidote for an opiate overdose. And when police are trained and equipped with naloxone, they're actually able to reverse overdoses because they're usually the first person that gets to the scene. In places where naloxone is equipped on police officers, they've seen marked reductions in deaths from drug overdose because they can get the antidote to people faster than the first responders from the ambulances. It's a really, really significant policy. Now in Iran, they decided in the late 90s when they were designing this, they designed a program called a triangular clinic. And the triangular clinic logically has three primary components. They decided to focus on three of these policies. The first was STI treatment and testing. By treating HIV, so if somebody tests positive for HIV, they can be started on treatment. And the treatment that we have today is so effective that we can actually suppress the viral load in their blood to a point where it can't be detected. Now, when you can't detect any copies of the virus in the blood, that means that the person will not progress in the infection. They won't progress to AIDS. They can live a completely normal life. And most importantly, when the viral load is suppressed to an undetectable level, they can't transmit the virus to other people. That's something that's really significant that was only acknowledged by the WHO in the past year, that undetectable means untransmittable. The second component of their program was needle exchange. So needle exchange is a program whereby people can go and give their old needles in exchange for new needles that they get for free. Needle exchange ensures that people use only clean needles for their injections. They ensure that they don't share the needles with other people, and they ensure that the used sharps are disposed of in a safe way so they don't get littered on the side of the road or on a beach or something where somebody might step on them. That's a really big deal because there actually are a lot of people that have stepped on sharps and become infected with HIV. So this is a really, really significant component of their program. And the third component is methadone maintenance therapy, which is a type of replacement therapy using methadone, which is an opiate that is taken orally, and it activates the same receptors in the brain as heroin, but without providing the high. Therefore, you can stop people from having withdrawal symptoms while at the same time allowing them to sort of live a normal life. When I was in Iran, I had the chance to meet several people who had gone through maintenance therapy. And in doing so, they were able to get jobs, return to their families, support their families. It really allowed them to get their feet back under them. And this is a really, really significant portion of their program in terms of getting people back into ordinary lives. Now, these policies are criticized and illegal in a lot of places. In fact, in the US, it's illegal for the government to fund needle exchange programs because a lot of people still think that these types of programs actually encourage people to use drugs, which is not the case. Most people, I don't think, set out to become opiate dependent. It's something that happens by accident. And most people who use opiates would like to stop using. The reason that they continue to use is that it is so difficult to quit. And that's why these types of programs are so important, because they provide the framework by which people are able to start taking those first steps. Now, Iran's triangular clinics were enormously successful. By 2003, they were recognized by the WHO as a best practice model for addressing HIV in injecting drug use communities. And by 2012, they'd almost completely stopped transmission among injecting drug users that were tracked by the government. Now, Iran's HIV program only captures about 1/5 of people living with HIV in Iran. So there's still some progress to be made. But this program is really groundbreaking, and the people that it did reach, it has had an enormous impact on their lives. Obviously, there's still some challenges remaining. Iran's not doing enough to address HIV that's sexually transmitted or between MSM, men who have sex with men, another critical risk group. But the fact is, they've made enormous progress that has not really been discussed or looked to from the rest of the world in addressing HIV and injecting drug use communities. These kinds of programs need to be implemented elsewhere, because the fact is people are still using drugs here. They're still using them in the US, in Latin America, in Russia. Enormous HIV outbreaks are happening. In fact, I was really sad to hear about one in Wisconsin recently. And that's because this type of harm reduction program isn't available to people. As I mentioned earlier, this crisis is only going to continue to affect millennials even more, and it's up to our generation to both demand this type of common sense, compassionate policy, and to look around the world for unusual solutions from places that we might not expect. Thank you.